Hello, my name is Nobuko Hijiya. I'm from Columbia University in New York City. I would like to talk about stopping TKI in children with CML. As you all know, tyrosine kinase inhibitors, TKIs, changed the landscape of CML treatment drastically when imatinib was introduced in late 90s. And after that, second generation TKIs, dasatinib, nilotinib, and bosutinib, and the third generation TKI, ponatinib, were introduced. And around that time, this concept, operational cure, was proposed. That means cure with lifelong TKI. Now we have a newer class of agent, STAMP inhibitor, asciminib. I'll mention that towards the end of my talk. So the result of this TKI, the improvement of the outcome of CML in children and also adults, is so obvious in this figure. This slide came from the German Childhood Cancer Registry. I borrowed this slide from my German colleague, Dr. Meinhof-Stork. So compared to the time the patients who are treated with transplant or interferon, the imatinib made the outcome significantly improved. CML in children is a very interesting disease. It is different from adult disease in many ways. We used to think the disease itself, CML in children, is the same as adults simply because they all have Philadelphia chromosome. However, we do see some differences. For instance, the clinical presentation seems to be a little different. And also more recently, we started seeing more results to show the difference of the biology between children and adults. Since this is not the scope of my talk today, I will not go into the details. But regardless of the difference or similarity of the disease between children and adults, no one would argue the host factors are clearly different. Children are growing and developing. So there are different TKI adverse effects in children, and also children live much longer than adults. So that may need some different approaches in the treatment. So let's go to the this main topic, TFR, treatment-free remission. I did tell you about this concept, operational cure with lifelong TKI. But now the concept is shifting to operational cure without treatment, treatment-free remission, TFR. So that sounds so wonderful. The patients can survive without treatment, but it may not be so easy and it may not be for everyone. So here's the simple concept. Patients with CML in chronic phase start TKI and they go to molecular remission and they achieve deep molecular response. And when they sustain this deep molecular response for years, and then they meet the criteria to stop TKI, they stop TKI. And then half of the patients' disease does not come back. They stay in molecular remission, treatment-free remission. But the other half have molecular relapse. That happens usually in the first several months after TKI is stopped. But when TKI is resumed, the vast majority of the patients go back to deep molecular response. So there have been many studies that have been published in adult oncology. I just picked several of them and made a summary here. The TKI that patients received prior to stopping TKI varies. And the eligibility for TFR, the criteria to stop TKI varied also, but most studies did use MR 4.5 or MR 4.0 at least 1 year or even more than 2 years. So when they met the criteria, they stopped the TKI, and 40 to 60% of the patients stayed in molecular response. That means TFR rate of 40 to 60%. And most studies used MMR, MR3 to restart the as criteria to restart the TKI. And when they restarted the TKI, most patients did go back to molecular response. In pediatrics, we have very little data and experience in terms of TFR. This study was published by a Japanese group. They looked at the 22 patients under 20 years old. And the criteria to stop TKI in this study was TKI treatment at least for 3 years and MR 4.0 at least 2 years. The definition of molecular relapse was either losing MMR or restarting TKI. And in this study, TFR rate at 12 months was 50%. So the number was pretty consistent with that in those adult studies. One interesting thing about TFR, treatment-free remission, is that even after TKI stopped, the level of BCR-ABL values may continue going down. This figure shows that. So we think that's because of the immunological depletion of residual leukemic cells, even without TKI treatment. This is a very, very interesting finding. Let's talk about criteria for TFR. Based on those many studies that have been published, TFR has become a standard practice for adults with CML. There are several guidelines and recommendations out there. I'm going to talk about 2 of them. However, it is not a standard practice in children yet. This slide shows the European Leukemia Net recommendations for TFR. And there are many factors that they mandate or they suggest as minimal or optimal criteria. But we need to know that this was made for adult patients. And one of the most important criteria would be the duration of TKI therapy and the duration of DMR. In this ELN recommendation, they say the minimal duration of TKI therapy is 5 years. In case of second generation TKI, it should be at least 4 years. And the minimal duration of DMR, MR4 or better, at least 2 years. But optimal duration of DMR should be greater than 3 years if we use MR4. And if we use MR4.5, that should be at least 2 years. NCCN guidelines that are used in the US, they have this criteria for TKI discontinuation. This looks a little bit less stringent than the ELN recommendation, but still that's pretty similar. Again, this was made for adult patients. And they say the minimal duration of TKI therapy is at least 3 years. And the patient should be at least in MR4 for over 2 years. There are some predictors of successful TFR. This is a summary of some published data in adult patients. There are some clinical factors and there are some biological factors. First of all, no one would argue 2 of the most important factors would be the length of TKI treatment and the length of DMR. And interestingly, among the adult patients, older patients tend to do better with TFR. In terms of the biological factors, E14A2 type of transcript, patients with this type of transcript do better than the other common transcript type E13A2. And also higher number of immune effector cells and the low number of suppressor population, they go with the higher success of TFR. So when patients are in molecular remission on TKI, why do we need to think about stopping TKI? Because there are some benefits, especially in children, because children have longer life expectancy, and because of that, they may need several decades of treatment. And there are known and unknown long-term side effects of TKI. We all have seen that TKI treatment for CML can cause significant effect on growth delay. And that has been a big issue. And severe cardiovascular events have been an issue with the second and third generation TKIs in adult patients. Although we have not seen serious side effects in this category in children yet, it is possible that they may develop that after several decades of treatment. And also some adolescents and young adults, young female adults, they may want to start thinking about their getting pregnant. But the TKI could cause adverse adverse effects on the fetus or pregnancy. So that would be ideal to stop TKI if possible. However, as I said, it's not their standard practice in children yet. In the children's oncology group, we have this ongoing TKI stopping study. Again, TFR is a wonderful thing that we could offer to our patients. However, there are some issues that we need to be aware of. First of all, the proportion of patients who become eligible to stop TKI is not high. That's actually pretty low. And for higher success of TFR, patients need to be on the TKI treatment for a long time. And specifically for children, by the time TKI stopped, the growth delay is already significant. And some patients who stop TKI can develop a withdrawal syndrome. That's mainly musculoskeletal pain. And there is data showing that significant number of adult patients have anxiety to stop TKI. And in fact, some adult patients refuse to stop TKI, even if they meet the criteria to stop TKI. And also, once they stop TKI, frequent monitoring by PCR is really crucial. So some patients think that it is inconvenient. In terms of the growth delay that I have talked about, here's a typical pattern. This figure shows the pattern of impairment of longitudinal growth in pediatric patients on imatinib. And even after a year or so, the growth starts slowing down. And as time goes by, that becomes even more significant. I often get this question from other pediatric oncologists. So which of the 3 TKIs that have been approved for children, imatinib, dasatinib, and nilotinib, which one causes least growth delay? I think they all cause growth delay to a similar degree. We don't have any randomized trials to compare that, but the degree of the growth delay is all similar. This study is from phase 2 dasatinib study for children. And not very surprisingly, prepubertal patients are affected more significantly. And this is the result from phase 2 nilotinib study in children. Again, the pattern of growth delay is very similar. So I did say by the time pediatric patients are ready to stop TKI, the growth delay is already significant. Let me explain that using this figure that I already used. So by taking the NCCN criteria, the minimum duration of treatment before stopping TKI is 3 years. So by the time they are able to stop TKI after meeting the criteria, the growth delay is already significant. So the question is, can we induce deeper and quicker molecular response to increase a chance of TFR while minimizing toxicities? I mentioned this STAMP inhibitor at the beginning of my talk. Asciminib is the drug that is currently approved for adult patients. STAMP inhibitor stands for specifically targeting the able myristoyl pocket. Let me explain how this drug works and why we are so interested. So in a normal situation, there is autoinhibition of ABL1 kinase because there is this myristoylated N-terminal, and when that binds to the myristoyl pocket, that fixes the conformation of the kinase to an inactive state. However, when BCR-ABL translocation happens, this N-terminal is truncated. This is how the kinase is constitutively activated. So asciminib, an allosteric inhibitor, binds to this myristoyl pocket, and then that brings the conformation back to the inactive state. So because asciminib binds to a different spot from the existing ATP competitive TKIs like imatinib, dasatinib, and nilotinib, they have different mutation profiles that can be beneficial. There are some published studies in adult oncology. The initial phase 1 asciminib study was published on New England Journal in year 2019. And in 2021, there was a study that was published on Journal Blood. That was a phase 3 study with the asciminib or bosutinib as a third-line treatment. So based on these studies, FDA granted the accelerated approval in October 2021. And another interesting idea would be if combination of asciminib and ATP competitive TKI like imatinib would be beneficial to induce deeper and faster molecular remission. And there are some ongoing adult studies. What about asciminib for children? Again, ATP competitive TKIs have off-target effects, and it may cause various side effects, including growth delay. Allosteric inhibitors like asciminib are specific to ABL kinases. So in theory, there may be less effect on growth. And also, we are hoping that it may induce deep molecular response more rapidly, and it may help TFR. There is an ongoing pediatric phase 1 study. So in summary, TFR by TKI discontinuation is more beneficial in pediatric patients. However, TFR may not be feasible for all patients. And also, there are some issues that we need to work on. And to make TFR more successful while avoiding side effects, new agents and combinations are needed to induce deep and sustained molecular remission more quickly. Thank you.